Good afternoon, everybody. We're very glad that you can make it here to our follow-up webinar CPD, following the one that we did here at Royal Clinic with me and Dr. Lowe at the moment. My name is Matt. I'm the practice manager for Dr. Lowe, and my background is in laser eye surgery and refractive surgery in general. And in my previous role, I used to be the chief laser technician at Morford's Private. I'm now currently with Dr. Lowe, and Dr. Lowe practices both in the NHS and privately. We just request that if you refer to us from Southeast or Southwest London, you have to refer to St. Thomas's by the usual pathway that you usually do. Outside of this catchment area, you can refer directly to either myself, matt@santilo.com, or to Catherine at admin@santilo.com. And on that note, I'd like to hand over to our wonderful PA, Catherine.
Hi all, I am front of house and PA to Sansi. Been there for about 3 years, many of you probably know me. Yes, you can get hold of me on admin@sansilo.com and call me on 0203 868 6231 and on to Anika.
So, hi everyone, I'm the face behind all the emails and things that has been giving you guys all the information. Welcome and thank you for joining us for our first webinar. So my name is Anika. I'm an optometrist by background, and I've been working since early 2026 with Miss Lowe and the team as an academic research assistant. So there.
Good. Anika helped a lot to prepare the slides, so we'll let her talk about the amblyopia part of the management. We've also got some orthoptists with us today. Very fortunate to have Leslie Stewart, and maybe we could also have a bit of a chat about your questions about amblyopia. It would be really nice because we're monitoring the chat. If there's specific learning objectives at this point, what do you want to get out of today? Then we can try and meet them as the talk ensues. So what would you like to learn about amblyopia? What confuses you the most about amblyopia?
Okay, guys.
So I think I was...
Yeah. Okay. So we were just to go through just a little bit of housekeeping in the beginning, and then we'll just reiterate right at the end as well. We're really glad to have so many of you guys with us today. We just request that, like Sansi said, that if there's any questions, feel free to post them in the chat. We're more than happy for one of us to pick up on answering them. And it's a safe space, so everybody's can express their professional opinions, and we're just here to kind of provide a learning collaborative environment, and hopefully you enjoy.
Lovely. So this is my slide, something about me. So some of you already know I am a consultant ophthalmologist at St. Thomas's Hospital. I also have a little team for my private practice, whom here today, whom I want to introduce to you guys, to put a real human face to show you how our bespoke boutique practice really works. Today, we're sharing a number of cases to talk about when there is asymmetrical vision, adult amblyopia. So it's no longer a childhood condition. And as we are a vision correction practice, I perform everything anterior segment, cataract surgery, glaucoma. I have a PhD in glaucoma, refractive surgery, refractive implants like implantable Collamer lenses, as well as LASIK presbyoond lens smile. So in order for you to understand how we do that and why we have this suite of work, these cases will help you understand our practice and a little bit about how we do things holistically and why I've selected this wonderful 3 members of staff to support your referrals coming to us, which is refer@sansilo.com if you want to reach the whole group. So today's lectures are going to be about amblyopia. A lot of you in practice will probably have noticed something about the depth of amblyopia, the amount of amblyopia, or the demographic. Most of us have children, or a lot of us have children, nieces, nephews, etc. Have you seen any of that in your practice? Some of you might also be myopia control experts. We had your very helpful registration forms because we want to use this occasion to get to know you, get to know your practice and how we can work well together. Often we run our CPDs with a group called the OCCS, which is a complaints consumer group complaints run by Paul Chapman Hatchett. Our next CPD event will be on the 13th of June, which is a Saturday, here at the Real Clinic, where you can come and see some of our facilities. Real can do AXA, Bupa, NHS patients, as long as they are not in the South East London or South West London areas. If you want to refer to me for the South London region, where the ICB and I represent the cataract service in the South area, ICB has to go through St. Thomas's. Outside of region, you can send to refer@sansilo.com, because we have particular expertise in glaucoma, refractive surgery, things that you feel might require my expert opinion, like someone who's had LASIK multiple times, repeat treatments, strange biometries, stuff like that. Send them to us for review. Today's talk is going to talk about neuroadaptation, because you know that the eyes see, but the brain knows. So the eyes cannot see what the brain doesn't know. So even if we get perfect optics, that's only 10% of the seeing and the interpretation, which is why some people can have multifocal lenses and be really unhappy because of halos, glare, and stuff like that. But as a team, or as my service has developed over the last few years with cataract and refractive surgery and my busy practice at St. Thomas's, we've really learned how people see in adult amblyopia. So is phaco-IOL in a densely amblyopic eye too risky? That's exactly what we're going to talk about today. Fantastic to pull up that question, Tina. And we have 3 cases for you today and a bonus case. The bonus case is an ICL case, but I just wanted to highlight it to you because after lens surgeries, there may be long-term complications. And when we're choosing surgeries and there's asymmetry, there is always the risk and benefits to think about. And I always think about it in 3 ways, which is the patient, the eye, and the environment. So objectives today is to repeat what we did in our face-to-face meeting, which about 30 people attended that day, and now we get to spread the learning to more people, and you guys can spread the learning to more people who can come to know we do. So I'll hand over to Anika to do the first bit, which is a case that was brought to us by the OCCS about a child.
Okay. So what I'm going to do is just pop this on the slide. I'm going to read through the case with all of us here, and then we've got some discussion on the next sort of slide that we can kind of go through. We'll give you a few minutes to do your own management and what your thoughts are upon this case. So this is going to be my child. Okay. At my child's initial appointment, when you used drops, you prescribed lenses with a +3 in one eye to prevent amblyopia. 8 months later, we had a follow-up appointment, which was very cursory, no dilation. Yet the prescription was altered to a +1.25 diopters, a substantial and an incorrect adjustment. He wore these glasses for 3 months, experiencing increasing discomfort. When we sought help ahead of the next scheduled appointment, I was advised very dismissively to stay the course. Again, no full examination. After which I was advised that the next checkup was a further 5 months away. Frustrated, we took private consultation to Moorfields Eye Hospital, where a pediatric ophthalmologist did a full examination with a dilation. They concluded that he was struggling because he required a prescription of a +4. When I asked if it had caused harm, she explained that an incorrect prescription with amblyopia is the same as not correcting it. And without correction, it only worsens. She stated that his first prescription, a +3, was probably correct. Due to your oversight, he wore the wrong prescription for nearly 8 months, a highly detrimental delay for a young child with amblyopia. The rapid eye health and progression of his condition due to your negligence cannot be overstated. So this was actually a real case presented to the OCCS. The child here is 8 years old. And I'm just going to show you this slide. maybe if you could take a picture of this slide, what I can do is I can flip back to the previous slide, so you guys can have just a few moments just to sort of have a think about what you think, and then we can go through the case discussion points. Is everybody okay with that?
So because we've muted everyone, just in case there's too much noise in your room, it would be good if you could put your answers. Number one, how would I manage the case?
So what I'll do is I'll pop the question in the chat and then I'll flip back to the slide.
So if this happened at your practice and the patient and the parent is very upset with this delay and this prescription, how do you escalate your learning between your colleagues in the practice? And how do you go forwards with it? It's easier in face-to-face because this is a repeat of the face-to-face, you know, so that as many people can benefit from the teaching as possible. So we did this with a groups of 6 people, and everyone shared in their practice whether they've seen something like that. Yes. That's the first thing the patient wants. The mother really wants, correct, Tina C, because when an event like this happen, and actually the neurosensitive age is already slightly over, and at 8 years old, you still have capacity to adapt, and it's important to get the +4 prescription. Accurate. Oh, Leslie, maybe you want to come on and talk about the case, Leslie?
Can you hear me okay? Yes. Yes. And my initial thoughts are obviously.
Yep.
Yes. Yeah. Was that obviously a good dilation was done at the time. Obviously prescription was dispensed, which is good. My question is why the patient was dilated a second time. And obviously going from a +3 to +1.25 non-dilated is quite an unusual change in refraction. So that in itself is an examination that probably wasn't done fully the second time. And the question is why reduce a child who's already in a +3 to a +125. Also, you're launching visual acuity, it would be good to understand that. But generally speaking, a child who's already been dilated, then reducing a plus prescription and an undilated, potentially amblyopic eye is not normal practice. So I would want to know probably what the visual acuities were, but generally speaking, a dilation potentially should have been done again. And the prescription shouldn't have been reduced undilated.
So that's from orthoptist, you know, Leslie, it's orthoptist opinion, definitely. So it's important to split it into 2 bits. You need to meet the patient's expectations. Clearly, they want an apology and some accountability, because in their mind, there has been clear harm with highly detrimental delay. So then you want to do your professional bits about rechecking that, and then explaining your findings and also talking to the team, because it may be a team member without, you know, regularly or having been in the practice regularly, or new team member or pre-registration team member, stuff like that. And the apology and the duty of candor is important to know. And is this a fitness to practice concern? There was no fitness to practice concern. The cyclo exam is important, just as Leslie has said, and you want to understand the circumstances with the optometrist that did it that day. Were they really rushed? Was there a reason they didn't dilate the patient? You know, then the whole team would then be able to learn from a complaint like that. So looking back at the records to reason from it, ask the optometrist that saw the first patient, why was it that there was no cycloplegic refraction? And then it's really important to do comprehensive learning and mediation in this case, so that the constructive feedback can inform your practices, you know, dealing with children or dealing with amblyopia, and sometimes building in a teaching session, or that's where we come in, See sooner, 6 months, apologize to the patient, definitely. This was investigated, but it didn't pass as a fitness to practice concern. And it's mainly to look after the patient and the child. So incident report, look at the root cause, continued training and improvements. So is this something that you have come across before, a complaint similar to this, or people can put in the chats?
I think I will also
Anika?
mentioned the importance of record, where Sansi's mentioned the importance of record keeping. When we are seeing our patients, how many of us are having these conversations, but from a medical legal perspective, and also a follow-up perspective for this patient, if we are not going to be the optometrist who are seeing them again, we require to have a really good consolidation for a follow-up. So in terms of what advice was given, have we given them written information? Because how many of us go to a GP appointment or a hospital appointment and we are unable to retain that information being said at us, and also making sure that whatever records we are keeping, for instance, if we are adding the VAs or we're looking at the stereo or whatever test, a clinical examination we are doing, should be reasonable enough for somebody else to follow up if you are not going to see that patient. And like a lot of people are mentioning in the chat as well, the maintaining the candor, having that responsibility and accountability, because as a parent, you, as an optometrist as well, or any healthcare professional, you want to make sure that that is the kind of treatment that your own child would be receiving. So obviously in this case, the mother's really upset, but we are utilizing it as a learning opportunity to make our records better, to actually use that within our practices to review how we are processing these types of cases, and also to understand what in the future, if we have this type of case again, what can we do to make sure that we don't end up with this result again.
There are some very nice suggestions as well about the goodwill and the taking responsibility, acknowledging the situation, because what parents really want is that it doesn't happen to somebody else. It doesn't happen to the next child, doesn't happen to other people, and they want to see that learning, and that often comes up when we do our sessions with OCCS. Half the time it's because they don't want other consumers and their next door neighbor to have, or a 2-year-old, maybe not two, but maybe at the school screening test, the 4 or 5-year-olds, to have the wrong prescription in your neurosensitive time and really impact another person. So what happens when these kids get a little bit older? You know, the common teaching is nothing can be done. So if you end up with 612 in the amblyopic eye, that's quite lucky. But if you're 660, for example, you know, what interventions? Yeah, not experienced that in practice. That's a good thing, Arun. So what interventions are there? And as an adult practice, we only see patients from 9 onwards because we have some software neuroadaptation training, and we always work with the ophthalmologist looking after the child, as well as an orthoptist like Leslie, and we have a few orthoptists at St. Thomas's as well. You can always get a joint opinion if you send patients to us that have slightly more complex BV type issues, because we're supported with good team around us. So Anika will now tell us, we'll go through this quickly so that we can get to the cases. Amblyopia.
Okay, so just to kind of give you a whistle-stop tour of what exactly is amblyopia. So essentially it's where the brain is learning to ignore or suppress the signals that are being received, or the input being received by one of them. Now we can classify the there's many ways to classify different types of amblyopia. Just to give you a brief overview, so we've got strabismic, where the ocular misalignment, where one of the eyes is not looking in the primary position. As a result, this also has implications when the child has a strong family history, either their siblings or their parents may have it, and as a result, you end up with strabismic amblyopia. We can also see children who may have anisometropic amblyopia. So in this case, one of the eyes has a stronger prescription than the other, and therefore you have two different sizing of images being presented on the retina, therefore causing a defocus. We also can have, you do have you have a relatively equal refractive error, but it is relatively equal in both eyes, and because it is quite large, there is blurred retinal images. Now, there is another type, less common, but the most difficult to treat, and also can be most detrimental to the children that it affects. It's often caused by a physical obstruction, so such as children with congenital cataracts or those who suffer with lid ptosis. Now, we were looking at how COVID has had an impact on this cohort of children. Now, about 1 to 1.5% of the global prevalence, global population actually suffers from amblyopia. Now, when we look at COVID and the impact of it, there are so many different things that we need to consider. So those children who are already diagnosed as amblyopic, there were fewer outpatient clinics that follow-ups were doing. Not only that, there's also the fear of going into the for those who did have appointments scheduled because of fear of infection, for instance. Or there were other pandemic-related restrictions that stopped these children from getting the help that they needed. Not only this, but actually during that time, there were fewer vision screenings taking place. So those children who were most at risk with amblyogenic factors that may have been present, those were not getting picked up. And as we all know, we need to have that. The earlier that we can pick up these things in the children during that critical period, the more chance for a better visual prognosis is there. So there was actually an 80% reduction in the amount of children going through these visits, these follow-ups, and also even community access to generalized treatments and referring into them. So picking these things up and then in the community, then sending them to the hospital. So that little breakdown had caused an effect. We don't have enough long-term research to be able to say whether or not these children that were affected during that time, who are now young adults, have had a significant impact on prevalence or the severity or the depth of how their visual prognosis has developed. However, traditionally, they have been told that nothing can be done at that. Now, we're going to kind of explain that actually that may not be the case and something can be done.
So we a treatment called Revital Vision, which is a neuroadaptation programming software. But when we ran this event live, we also had a live poll called Mentimeter where you could click in and do some answers. So we're going to try and re-simulate that here again. Do you guys want to try and answer A, B, C, or D? What is the global prevalence of amblyopia? You can put that in the chat. Yeah, it's lowest in Africa, which is the slide that we showed earlier. Yeah, most people are answering C. And that is the answer. It can be up to 3% in some places. It may go up and continue to go up to be about 3.7. We don't really know because the long-term data isn't there and specific cohort data. Perhaps, you know, some of the ICB work on school screening. One of the IP optometrists that was sitting with me on Tuesday last week was telling me he sees about 12 of these referrals, maybe a month. And there may be some real world data that we can look at in 5 years time or 12 years time, But as practitioners right now, what can we do about amblyopia? During the COVID pandemic, what was the biggest barrier? Was it a biological change in the condition making it harder to treat, A? Or was it B, lack of access for computer training that amblyopia got worse? Or inability to attend scheduled follow-ups? Or was there a global shortage of atropine and eye patches? What's your answer, A, B, C, or D? Why was there reduced treatment compliance? Yeah. So that one was quite clear from Anika's background research. And we then move on to what we offer at the practice. And we've got something called Revital Vision, which really started because there are two suppliers of this. One is called Binox and Revital Vision, and possibly a few others. I came across it at a conference where they were using red-green filters and adjusting for multifocal lenses. Such that when people couldn't get used to their new multifocal lenses, they put them on computer software training, and that improved their ability to accept halos and glare. And then I looked around to see what was available when I was starting out my private practice 3 years ago, and we built a base around Wimpole Street. This FDA-approved software called Revital Vision has now been proven and treated in 15,000 people worldwide. One of the biggest groups was in India. I grew up in Singapore, so I go back to see my family every year, and group between Singapore, India, and the refractive surgery in Asia is just such a big thing because of myopia, and a lot of you are myopia control specialists. Revital Vision actually allows you to treat low myopia up to about -2 diopters, a bit of amblyopia. So anyone who's like 618, 612, you could probably get the 2 lines to get them back to driving standards to 6'9". You can treat multifocality, you can treat Parkinson's. I've recently started a patient on who did really, really well with 2 extended depth of focus lenses, but as his Parkinson's started to progress, he was finding it really hard to focus. And it wasn't even a multifocal lens. So it really begs the question, with all of these multifocal lenses just being put into people without understanding corneal topography, corneas, glaucoma risk, or AMD, what happens with that 45, not 45, but the protocol is 50 years old for lens replacement or, refractive laser surgery. What happens to these guys when they get to 85? What if they get AMD? What if they get other diseases? So as a glaucoma trained person, primarily in my early career, I've always been a bit more conservative, and we usually do EDOFs or monofocal plus lenses, trying to simulate the range of vision by looking at the dominant and non-dominant eye, instead of going for multifocality, because I want to future-proof them until they're 95 years old with the sharpest, lowest, the maximal contrast vision. But we also have the neuroadaptation training in place. We haven't reported this for ESCRS because, but we have 3 abstracts in ESCRS with my refractive surgery results, the care of elderly patients having cataract and refractive surgery. And what was the third one, Anika? Was it portable devices? Yeah, we also have portable devices for frail patients in care homes. So I love our research active practice. So really, really pleased that you guys are joining us, because we want to do things that are evidence-based. With Revital Vision, we can send around some papers as a follow-up for these wonderful 40 people who've joined us today. For the scientific evidence, but for the practical stuff, I'm running this with a Macintosh computer, but a cheap regular mouse that is attached by a USB. Why is that? Because Revital Vision is based on Gabor's patch. It's the smallest discernible grayscale that the brain can perceive. So some scientists took it, and we actually have to do a little declaration because of the war in Israel and the Gaza Strip. Some people are just like not doing anything Israel. This software is Israeli, and the headquarters is in Israel. The delivery is at home. You can access the software at home. Anyone from about 9 years old onwards. Let's say you've got a child that's just got, or even if they're really densely amblyopic, if you could 3 lines of vision, you know, you can refer that to Anika. You can refer these Revital Vision patients and tell Anika about them, and we can get them onto a program. They do this at home every 3rd day. They show the software shows you gray patches in their level of astigmatism, and then the opposite, and then smaller, and then the opposite, and again. And it's almost like a computer game, so the kids can do it. The only demographic that has not been able to successfully complete Revital Vision, we've got about 30 or 40 cases now with results, and we're getting an average of 2-line improvement in my cohort, mixed with post-cataract, amblyopia, low myopia, presbyopia even, averaging a 2-line improvement. And if they do get the improvement, not everyone, I suppose we will find the occasional one. It's a small set now of 30 patients that didn't get an improvement. The compliance is poor with the young mothers. Anyone with multiple children and young mothers, they just don't have the time to commit to this. And you need to commit with this kind of mouse every 3rd day for 30 sessions. Typically takes about 10 weeks. So after 10 weeks, and if someone, so one of my clients was a engineer, which is very sensitive to a 1 diopter of SIL. It's not enough to laser again. It's definitely nothing to rotate on toricity. And just that cylinder was making him really unhappy because he was 6'9" and the other eye was like 6'6" or 6'5". We put him on Revital Vision and he came back delighted. Just started to accept the 1 diopter of cylinder. And so, you know, this is something that really supports our practice. The safety considerations are you shouldn't do this on anyone with more than 8 prism diopters of eye deviation. Proper double vision will get them to see Leslie or our orthoptic colleagues. And precaution if there is severe untreated ADHD or the strobe effects because of epilepsy. They need to be able to concentrate and do this significantly. A whole group of patients can benefit. If you have any questions, you can call Matt because he usually starts them on the software and then he tracks the progress of the patients. We have one case that we're going to show that had Revital Vision completed, and the second one is about to start it, a very complex case that was referred. And then the third case was a usual amblyopia that answers Tina's question about whether we do cataract surgery in amblyopic eyes. Now, we have a question about the clinical and contraindications. Is it age of 40 that you can... So everyone's already understanding the deviations. And what is the projected lifetime risk of vision loss when somebody has amblyopic? What are the chances people will lose their vision in both eyes? I think this is the lifetime risk of vision loss, binocular vision loss. What is the projected risk? Is it 0.3%? I think the D's are all the Revital Vision contraindications. We've moved to the next question. Do we think that the projected lifetime risk of vision loss is 0.3%? 4.5% or 1.2% or almost 12%? Most people are settling for about B. A few C. Yeah. There you go. That's why Leslie is our orthoptic and BV expert on this call. It's so nice to have Leslie here. You know, so the projected risk is actually quite small. However, everybody would want the best chance of getting their best vision. So I personally, well, I have an interest in this, but I personally think that if there was one major choice you had in life, it would be when to have your permanent vision correction surgery. Because so many people, up to 70% of the people in the world wear glasses long-term, different stages of life, presbyopia and all that. And there is a time and a choice for you to make of when to make that choice to make your best chance of getting good vision. Amblyopia, do you think it increased the COVID pandemic? Did it increase the prevalence? Did it go up by 0.8%? Did it increase amblyopia at all? Maybe it didn't. Is it a no? Is it yes, A? B, no? Or do you think that the depth of amblyopia got worse? It's much worse in one eye? Or do we think that we don't know, but actually there's a risk multiplier? Amazing. We've got such a wonderful group. You know all about this. Fantastic. So insufficient studies cause, yeah, I did her research, exactly. So now we go to the cases, and we'll do that in the next 20 minutes or so, and then leave some time. We'll unmute people, and so you can ask your questions. So this is an 85-year-old gentleman referred with advanced cataracts. So this is one of our referral partners. Because we like to fine-tune our refraction, we usually send the patient back to you for the 6 to 8 week post-op. So we know to titrate your pre-op findings with our post-op results. So almost always we send you, Matt's responsible for making sure when I've discharged the 6 to 8 weeks, you get a letter back to say our results, and that you then send us a report at 8 weeks. And then it's a shared care program, particularly as I have an interest in glaucoma. So sometimes they get into intermediate visits to get their IOPs checked, and we'll send them to you. And also I support a lot of the IP training. I've probably done 20 over IP optometrists now. I mean, taught 20 over optometrists now. So we're building that strength and capacity in the community such that glaucoma patients get really active care. Am I based nationwide? No, I'm based in London, but people anywhere in the country, in the UK, with a GOS 18 form can be referred to us. We're mainly a private practice, but if the private practice slots are not full, and there is capacity, we take on some of the NHS work, and most of my other colleagues do the NHS work here. I'll take on the cases that I feel that I'm the best suited to treat them, like only eyes or post-refractive calculations that are difficult, that I think make a big influence in their care. Then you can even send somebody from Scotland to come and see me. So this guy is +4 - 3. So it could be that an isometropic type, because it's a very similar prescription on both sides, and his final outcome may not be so good, because we don't know if it's amblyopic from high hyperopia with astigmatism. The pressures were fine. When you get a +3 or more, you need to think about the angles. So Van Herrick's, you know, a quarter or less, and I did my PhD on the genetics of angle closure glaucoma. And so any refractive error +3 or more is similar to -6. Those two ends of the spectrum in the eye are genetic. So we want to look for glaucoma. One end, we're looking for angle closure glaucoma. The other end, we're looking for open angle glaucoma. He's had poor vision since he was for over 40 years, sorry. Yeah, so once presbyopia sets in, then, you know, they rapidly progress to the plus every year. And he came at 85. We corrected the astigmatism. However, with irregular corneal astigmatism that was made much worse with dry eyes, I selected a relatively conservative lens, which is the iHands, which is a Monovision Plus. That one and our Hoya Impress are our two best. A lot of you use Hoya in your myopia control practices, and actually the 13th of June event will probably be Hoya themed, where they tell you, I mean, we've had a lot of requests for people to teach about different lenses, what they do and how I select them. So if you can come to see us face to face on the 13th of June, I think we'll have at least one lens company, maybe more if they want to join us. This gentleman had an iHands in both eyes, and I told him that he's probably going to need reading glasses. In very small eyes, you get more CMO. So we sometimes give them prophylactically, but typically my protocol is just steroids, and it's 6 times a day for the first week and 4 times a day for 3 weeks. And that is because it's not a uveitis. So post-op regimes don't have to be tapered off 4, 3, 2, 1, etc., because it's to treat the surgical insult. If you got it right, and in the first week, at day 8, almost all of my patients are driving. That's because we've really intensively done the 6 times a day of the steroids. They've really invested in their 10 drops a day, 6 of steroids, 4 of dexamethasone. And if they get to day 7, my day 7 results are like 3 weeks results equivalent, because they're driving, they're seeing, we do monovision, and we do EDOF lenses, we do multiple refractive planning, we avoid corneal irregularities, we treat dry eyes. And so he was so delighted, he was planning to play golf at day 8. And then he came back with a shift in his refraction, it became a little bit more plus again. So this is what happens with really small eyes. You give them their first presbyopic pair of glasses, then it's +2.5, and then +3, and then they just eat it up, and then it's, you know, and even after the surgery, he came back with a little bit more plus. And then the astigmatism, because it was a non-toric lens, you know, I couldn't improve that. And at first, immediately post-op, look at his near unaided vision, and was N5. So astigmatism is not our enemy because it can be with the rule. It could help us with reading. I can give you almost perfect result on an NHS lens, or just a first level upgrade of the Eyehance lens, or if you have insurance, insurance takes care of everything, you're only paying for the lens implant. We can even do, if you're very amblyopic and you only want to invest in the dominant eye, actually we have a case, you want to make sure all your sill is corrected, unless you can't correct it for a corneal reason. Right, so we then put him on Revital Vision training, and this is what it looks like on the back end, and that's what Matt and Anika look after for me. So we have a set of patients going through it for all the different types of interventions. Each of these colors are each step of the size of that Gabor's patch getting smaller. So you can see as the patch gets even smaller, the red one, his vision has dropped. His vision has dropped back down to 612, and then it fluctuates again. So after we put him back on the Revital Vision, on the basis that it can be treating low astigmatism, on the basis that he was N5 and 6.9, what was the result? I can't remember. Immediate post-op was 6.7.5. So we wanted to get him back to nearly spectacle-free. And then his optometrist actually prescribed the glasses afterwards, which he didn't mind because the cylinder did help. But the after finishing their Revital Vision, he only wears his glasses for golf because he's really competitive. But going around, he's gone back to what we were the first 8 weeks, the first weeks post-op. And even at the 8-week post-op, when the refraction was sent back to me, he was still happy not to wear the glasses. It was occasional wear. So 95% of people that come to us leave spectacle-free. And if they are the 5% are not spectacle-free, they are occasional, and it's a specific reason. For him, it was to shoot the golf, to beat his friends at it. You know, and some people, it might be knitting or sewing. So we never guarantee spectacle freedom. We improve spectacle independence, and it falls in line with all the dementia patients that I treat at St. Thomas's Hospital. I want my 90-year-olds to be able to see their food. I think almost every 80-year-old should already have had the opportunity to have had their cataracts done. If something happens, you're not trying to do a GA on, you know, a really frail and heart disease and stuff like that. So that's the basis we work off. This was actually, we had an assistant, a medical student was summarizing these cases for us, and that's typically what we do, our op notes. You know, if the power is quite high, the CDE, which is the combined dissipated energy power, then we give some steroid injections. You know, I tweak and fine tune my perioperative care really carefully, whether it's glaucoma, AMD, or, you know, every surgery is personalized, even though we have high throughput. So the second case, maybe Anika can read through it. Oh, actually, let's play the video. Oh, there's a video play. Is it just a picture? Yeah, do you know if the video plays?
It should play.
Let me go to the original presentation. Any questions about the first case? Let me see. Let me go here and let me click the play. Sorry. Oh, this is actually a video. Why don't we send the video with the follow-up thing? But this is
Yes.
Yeah, we'll send it with your thank you for coming email, okay? And then you get to see the 2-minute video. So this is the summary of Barry. So Barry was, I was asked to see him because he got cataract in his only eye. And it was the VR surgeons that said, you must go see Sansi. Why? Because his local hospital offered him, he went up to his local hospital with floaters in his better seeing eye. So obviously with the amblyopic eye, if you did have a myopic of 6.5 and your PVD comes off and it's in the way, you will get very symptomatic. However, that hospital offered a vitrectomy and ILM peel because there was a small ILM at the time. It wasn't a bond or ERM, but they did that. Unfortunately, he then detached in his dominant eye. Before that, he was -6.5 myopic in both eyes and had laser refractive surgery when it first came on and was offered at Moorfields as part of a trial, and then had to have the laser surgery again because of nighttime aberrations, because at the time they used to use very small optical zones for the refractive lasers when the prescription was high. Now we use much bigger optical zones, and we also use femtosecond flips and other technologies to make our LASIKs much safer. He developed retinal cysts after the vitrectomy and a secondary cataract, which was then removed, but his dominant eye was given a plano prescription, and he constantly now sees a distortion in the center of his dominant eye. So by the time he was referred to me, he had debilitating floaters in his other eye because it was starting to happen. And I prescribed, or rather we asked him to buy on Amazon something called Vitrocap N, which is like a grapefruit extract or pineapple extract because it breaks down the hyaluronate inside the eye. And he was then offered that with Carbamide eye gel because of the dry eyes from the previous LASIK. So the plan for him, I have now treated his other eye, his amblyopic eye. We got his prescription pretty spot on, but he started to develop a very early PCO. And this is the strange thing. This is the second time I've seen it to get PCO within a month. It's not because we use lousy lenses, but the only other person I've got PCO within a month is a lady who had RK. And I think what happened then is the very, very early lasers that were done 40 years ago, or the RKs that were quite traumatic on the cornea, it drove a long-term chronic inflammatory response. So you get a much bigger response. Now, in learning that, I'm going to increase the steroids for longer. And in fact, he's now on PrEP for. We've just done his YAG, and he's got a full PVD, and he will then restart on his Revital Vision training. So that's why we wanted a series of things so you could follow some of our patients who've given consent to share their videos, to share their case for learning, because don't do a floaterectomy in a dominant eye, you know. And there's always a balance of refractive surgery, VR surgery, glaucoma surgeries. Ideally, you want no more than 2 operations in your whole lifetime, like a cataract one and a glaucoma one, or that, like at the one time, and do it the best. So my plan for him now is his other eye, which is the amblyopic eye, to retrain that with Revital Vision, because we got him to 612, and the other eye, the dominant eye with that glare and all that, is 615. If I can overtake that and do the Revital Vision to get him dominant. And the reason I know it works is because my mother-in-law referred her good friend to me who detached in her dominant eye, retinal detachment. So if it's just a refractive unit, they never see their detachments because they come to us in the NHS. We pick them up, so we know what these outcomes are like. So that's why I'm conservative with my monovision approach, because very, very high myops have a good chance of detaching, and at least one eye is a monofocal or monofocal plus, and the other eye can have the EDOF. Then you don't, and then I definitely don't put multifocals in both eyes, because I don't want this kind of a situation happening, where the dominant eye can't see, has an ERM and a multifocal lens. So my plan for him, same as my mother-in-law's good friend, who then had to retrain her amblyopic eye. She was 612, was bereaved because her husband, again, I have permission to share this, and there's a video of her, 612, she recently bereaved, and I think the sadness, and you can't see, and it's your only eye you detect, and her, bereaved with her husband, and giving her something to do. She did her 40 sessions of her Revital Vision training and continued for about 80 sessions, and headquarters hadn't stopped her sessions, and she went from 612 to 67.5, and she's driving again. So the borderline cases, we have to think about neuroadaptation training. This was Barry's topography. It's kind of tricky, really hard to do the calculations. And because I work with lots of different lens suppliers, I get great support from their scientific team. And we sent these measurements off to guys with Johnson & Johnson. He has eye-hands implant, which is a monofocal plus, a slight magnification. That's why we got him 612 from his previously 618. And look at the topography from so flipped the case are like 36, slightly off center, very, very old laser. And this was done twice to reduce his nighttime aberrations. So, you know, sometimes in a high volume NHS setting, they might not even be considering topography. So if I pick up a biometry on my new visit and I'm seeing that it's 38, 39, I'm going to ask for a pentacam and make sure of these things, because patients not always forthcoming to tell you that they've had laser refractive surgery, but it's been 40 years since refractive surgery was born, and now these guys are 40 years old, 80 years old. So we're going to see it more. We need to ask about it more. We need to be more discerning where we refer patients, because it's their only chance to get back. They paid for laser refractive because they didn't want to wear glasses. So if we then put them in like and give them a plus 0.5 outcome, a hyperopic outcome is the best predictor of permanent need for glasses. So we actually aim for about minus 0.5, and then the non-dominant eye gets about minus 0.75. Plano and minus 0.75, that's the difference. If I were to use NHS patient bilateral surgery, I would aim for plano and minus 0.75 to try and give them spectacle freedom. So then the last case is a 72-year-old gentleman, and he was referred to me to say that, same question, densely amblyopic, 660. Is it even worth referring? Is it worth doing? So he went to see the NHS and they said, no, you only have one good eye. I suggest we don't treat your good eye because it's your only good eye. And I also think that it's not worth treating your densely amblyopic eye because you're not going to see any better anyway. Is it true? So this is what we did. We did his cataract surgery. I used two different companies. The BVI trifocal lens is one of the market. There are other suppliers, and there is the Galaxy lens, which many of you might have heard about because it's a spiral design and AI design. And the Galaxy lens has got less glare and halos. But I needed to make sure that this guy with a densely amblyopic 660 eye. So there are a few circumstances where I will give a definite trifocal, and I give the best one, which is the BVI trifocal. That's if you're so dependent on one eye or you're really young. So I've got like young patients on steroids, eczema, renal transplants, those patients, and they come and see me and they're 30 something, they've got their insurance. You know, they need a trifocal lens because they need to continue working for the next 50 years. So they need to accept that there might be glare and halos. The Galaxy has given me a sort of semi-halfway point. So some people get the Galaxy and the enhanced depth of focus in the dominant eye and the Galaxy in the non-dominant eye. That's you know, gives me the safety of not putting two trifocals in case glaucoma or something happens. So this gentleman had the right eye LuxSmart, which is a true EDOF lens. What I mean by that is it's not just a little magnification in the middle, which is like a 0.5 add on the eye hands. This one is zonal with LuxSmart. It actually can give you up to minus 0.75 of depth. And if you're clever about optics and you use the corneal topography as well as the axial length, etc., and all the things that I have put together in my experience, you can get 6.9 vision. And the right eye went from 660 to 6.9. I didn't expect that. That was with the LuxSmart lens. And the other eye was 6.6 and 4.5. Totally expected. Because it was, and is it worth correcting the +8? Absolutely, because you know, how can you prescribe a +8? You'd only put a balance in or not prescribe at all. Is there a chance of improving? Yeah. Is there a chance of improving? And what's your modifiable factor? Choose a surgeon who's willing to do it and who's good at it. So, you know, those are the factors you want to think about when patients inquire and ask, because there are people who do have solutions like this. After intervention with the best trifocal at the time, with a little plus outcome, because when there is pathology and leaving it a little bit plus, it magnifies them a bit. Otherwise, I usually lean for a -0.5 outcome as the majority of them. So, are you still good for a bonus case? Because we've run out of time. This is our 7 o'clock finish of our amblyopia CPD. If people want to continue for me to teach the next one, shall I do the bonus case? Yes? Yeah? Okay.
Yep.
Oh, so the bonus case is not amblyopic, but I'm only highlighting it because it may be a solution for some of your people where you're just putting a balance and they have a -5 in one eye, right? So they have, let's say, 624, 636 vision. And if you put the full thing in, they can't tolerate their glasses, and you don't want to put a contact lens in daily. So contact lens related infection and laser risk is about the same. If you've been wearing chronic contact lenses for 3 or more years, your risk of acanthamoeba or some silly keratitis is the same as your risk of refractive surgery going wrong. You know, so really have a think when people start to struggle with their contact lenses. Okay, and this bonus case is actually a case that I was asked for glaucoma opinion. How do I get back to my slideshow? I think someone else might have to click because I've lost my slideshow.
I'll do it.
Okay, so the bonus case is a 35-year-old lady who was referred to me. Miss Lo, can you check the glaucoma? Because this lady had previous refractive surgery elsewhere. She was seen in her home country with ICLs beautifully placed 10 years ago. She was 25 years old. And she was -13.5 and -13. Perfect indication for this. Remembering -6 or more can have myopia, glaucoma, all those risks increase as they grow older. So, but 25 to 30, 35, that's the peak time when people are seeking refractive surgery because that's the best investment in their time. Imagine fiddling with contact lenses for 30 minutes before, after each day, packing all your solutions when you go on holiday. You know, that's the demographic that's looking to get spectacle free. So she went and had her treatment at 25. She reported severe dry eyes after ICL. That's not my experience. Typically, I get more dry eyes from laser refractive than implantable contact lens surgery. Maybe it's because I'm a cataract surgeon anyway. So, you know, we have quite a strict and significant protocol. We have Bavi, who does our dry eye perioperative work. And if you guys run a dry eye program, we want to know because we let you take care of the dry eyes pre-op, perioperatively. We love to support your practice. We will send the patients to you. We will advise on that. And then they come in and have the surgery with us. She had multiple corneal abrasions. And now a surgeon, the same surgeon in Italy, found that she's got glaucoma. She was given timolol eye drops and was short of breath and stopped using it. The ICLs looked good. The cup to disc ratio was 0.6. And this is the autorefraction for 35-year-old. That's good. So she's like, oh, can it be better? So it's a bit like the -13s. They're really excited. And then they're like, oh, it's 6.9. Can I be 6.6? That's the kind of thing you get with refractive surgery. So the counseling from the time you recommend a refractive surgeon all the way to the end is managing the expectations. You know, if we sell refractive surgery as we're going to be spectacle free for life, almost everyone will be disappointed because presbyopia is going to kick in. Refractive slide or the shift in the corneal topography and stuff, much worse for hyperopic lasers than myopic lasers. SMILE can only be done on myopic eyes. Hyperopic SMILE has only just come on the market, and that's London Vision Clinic and the Belfast Clinic, Cathedral, I think. They have hyperopic SMILE. But refractive surgery is not always permanent. So you want somebody who can offer lifetime care because you could get glaucoma, like this case. So I had visual fields, the pressure was good, and then when you dilate them, so actually pressure in the eye is a very physiological thing. I've even seen patients who are really, really stressed, have high pressures, and when the stress episode disappears, it goes down. Or patients who've reported to me, like, it seems to go with my menstruation. I can't explain it, but I know my pressure's high. They come in, they guess their pressure, and they're spot on. You know, it's one of those things you see clearly in the glaucoma clinic. But when she was dilated, probably because the ICL stands up a little bit, the pressure was 25, 22. She has loads of floaters with the -13. We said the same to her as we did with the other patient, have the vitro cap and then looked at her results. Her -13 was like pretty good outcome. over 10 years. This was a topography, and the ICLs come in toricities as well. So as long as the AC depth is deep enough, we need enough space to put in an implantable Collamer lens. It's just like a permanent contact lens. It's really tiny. You probably can't see it, but it's that is an IOL and that is an ICL on my phone. Yeah, the ICL has got 2 little plates, and we fit it very, very carefully, very, very gently, not touching the cataract at all, really, really super gentle, and we place it into the sulcus, so that like this on top, so that we don't want to rub on the lens. And there's usually a little acro point, because this was 10 years ago. There isn't a little hole in the middle of that ICL. Right, the ICLs have been around for over 30 years. And the safety track record is actually pretty good. It's less than 1% get cataracts if you go to the right people. The only surgeons that are doing these are the most experienced intraocular surgeons anyway. So she had a really nice result. However, she inherently has a glaucoma risk. Her macula was fine. Her OCTs look like this. So if you had a patient like this, would you say the patient's progressing? Can you type, look at the OCTs? Let me know. What do you think? Is the patient getting worse? Is there any glaucoma? Tina C says yes. 2017, 2021, 2025. Like most of you guys have OCT machines, isn't it? Exactly. This is why we need to do shared care, so that more people can get access to us and there are more of us to pick up this kind of stuff, because it's definitely getting worse. Now she's worried, you know, and now who is the right person to see them? Someone with experience on both ends. So I found myself in this little niche group of slightly looking after the tricky cases, having more options to offer my high myopes. But because I have such good links in the community with my MEX expertise, I've been teaching MEX optoms since I started as a consultant at St. Thomas's. So they'll just tell me where they live and go, right, go and see Kevin, or go and see, you know, Gordon, or go and see, you know, I know your practices. I'll send them to you, and you're much better at being able to track these long term, because you might already have had your OCT for 10 years and you'd be able to show me this. So she's progressed. What do we do? This is a visual field test, and luckily not too much. Yeah, because it's open angle, I can do some SLT treatment. Yeah. And there's just all of these complexities too. And also it's a little bit like hypertension. You don't treat on the first sign of it. She hasn't got any field loss yet. And I certainly wouldn't be rushing to go in to remove her ICLs. She's no cataract. She would not be served to go back to -13 again. And so my consenting of my ICL patients includes, what if I give you glaucoma as a result of treating your -13? How would you feel? And if they go, no way, I don't want ever to take eye drops, then sorry, I can't offer you the surgery. I can't offer you. You know, I have to make sure that whatever I put in, when they come to me towards the end of my career in another 22 years' time, I can stand up in court to say I did my best for the patient and I didn't cause harm. And this surgeon did a beautiful job, you know, really good job. But now it's passed on to myself to look after. But I also have a capacity issue because I have a busy NHS practice. My private practice is, you know, we've got a nice team now, so we're busy, and it would be really good to have shared care so that they go locally in the community. And we want to build something like a passport program so that all these things, the patients have what they need, whether they're seeing in Italy, here, or with you. They have education and health education training, teaching. That's what we do here. We can adapt that. That's why I've appointed Enrica, so that we can do it in like lay language, so we can tell people what options are there out there. First time they get their corneal ulcer and they stop wearing the contact lenses, but they're struggling with their -5s. You know, it's all about education. We're big into education. So this is progressive. And if you then know about normal pressure glaucoma, the normal pressure glaucoma, because of the subclavian, how the blood vessels go to the eye, the left eye is worse than the right eye. So she only dilated to 25 when the ICL was pushing. Most of the time it was 15, 15, 16. And then when you have normal pressure glaucoma, then I ask things like, do you get cold hands and feet? Do you take amlodipine? Because amlodipine drops your blood pressure at night. So we change people who have been on amlodipine to ramipril, because that doesn't have, that in a very large American study showed that people with glaucoma and amlodipine had worse visual field results. So, you know, everything that I learn gets translated into my practice. I do it for the hospital. I do it for St. Thomas's. I believe in medical education. I teach my medical students. I teach my IP optoms. I educate my private practice patients. We're not huge on marketing or anything. It's word of mouth that people get to trust us, and we look after your family members. If you and your family members need anything like that, we usually have a professional discount rate, you know, of something for the people you care about, because we believe that vision is not a luxury item. It's an essential. It's an essential characteristics, and if we have the right technology and the right innovation and learn how to use all of our tools properly, I just don't think anybody this A&H. I mean, I moved from glaucoma to refractive because I was just getting too sad that my patients were getting older, they were dying, and they had no vision, and it was just going one way. There was not as much joy as hitting your 6.5 outcome, or getting 0 because you planned for 0, or getting like, wow, 660 to 6.9. Incredible, didn't even expect that. So that's how I've ended up in my career, combining the two things. And we just wanted to share with you what we do, meet the team that supports me to do what I do. And, you know, this lady, I'm going to continue looking after her. And probably my next step is a little bit of SLT. And again, I want to hold it out, because SLT has a runoff effect. It only lasts for about 3 years. So what I really want to get to is to slowly shift her towards 50-55, watch for a PVD, and then I can remove that ICL, do her lens replacement for her -13. And I only get 2 shots of my SLT. So I really want to stretch it to the point where I'm sure she's progressing. Do the SLT, ideally try to get 3 to 5 years out of that, get another round 3 to 5 years in, and then she hits 50 years old, and then I can secure her vision longer term. And then at the time of cataract surgery, I will then put 2 little stents in, because I don't really believe in trabs and tubes and all of those things. It just means we got there too late. You know, you got to send them to me before they've got dense visual field defects. You got to send them to me when they're ocular hypertensive, so I can tell you what the phenotype is, whether it's NTG plus genetics, whether it's a narrow but open angle, whether it's a pigment dispersion syndrome. And for pigment dispersion syndrome, a PI only works in that very small critical window when they're between 21 and 24. When a PDS has gone way over 25, 27, the iridotomy just causes more harm, and then it will tip them into glaucoma. So that very tiny window of PDS, -5, nope, I'm not going to put an ICL on you. Nope, I'm not going to laser. I think I'd be uncomfortable lasering a -5 PDS patient, but I would do your iridotomy for you. But in that zone of 21 to 24, you put it into ChatGPT, it would say there's no evidence for iridotomy for pigment dispersion. So they'll come with Dr. ChatGPT, Dr. Google, and challenge you. So you really have to know your scientific facts. And we do that through study, and we like to share it with our optoms so that more people can benefit. Because you can take this and 40 more people will know that the next time tomorrow you see a PDS, you've got a piece of information you didn't have 2 nights ago. So that's why we do these. And so, yeah, that's the patient, that's the monitoring. We would love to work with you. You could follow us on Instagram. You can follow me on LinkedIn. You can chat to any of my team. And we're so good. We're only 12 minutes over, guys. This is a record for me. I speak so fast. I hope that's okay. 7:12, incredible. Shall we just CPD it, and then let's check out and put it in your diary? Come and see us 13th of June. And if people want it running again, we'll probably just send them the video, because I think it's been recorded. Yeah, and then let us know. Any evidence for nystagmus? Yes, I think there's a paper on it where they did it with some congenital condition with nystagmus. Yeah. I haven't offered it for Revital Vision, but we can, Anika, can you look at our Revital Vision folder for all the manuscripts to see if we can find this? Krishna, would you put your email there so that Anika can follow up for that? Do you have a particular patient with nystagmus that you're thinking of? if you could put your email in the chat, Anika will get back to you with the nystagmus paper. I know they've done it for keratoconus. I know they've done it for some congenital diseases. I can't remember which one. But if you could email support@sansilo.com, Krishna, if you email support@sansilo.com, Anika will find you the paper if there is RV and nystagmus. Any questions? Make sure you scan this. Matt's been taking down all your GOC numbers, and I think if everyone wouldn't mind a group photograph, let's see. We'll be sending out the recording. Yeah, we'll be preparing a recording, then you can access that, and then you can see Barry's video as well when we do that. That's very nice, Simon. Thank you very much. And then, yeah, brilliant. Very nice to meet you and wife Arun. And yeah, anyone who joined a bit later, we collected GOC numbers at the beginning. You'll be asked to do that again when you do this. Thank you, Tina C. Scan this code. Amazing. I see. Hi, Tina and Arun. Got it. Okay. So scan it, and then sometimes Paul will then check in with me to see if you actually came. Yeah, thank you. Actually came. So we have proof of attendance with your chatting with us. Thank you. Thank you, Kay. And Kapchi. And if you're in a practice where you have to refer to somebody, but you think somebody should see me, just tell them to Google us, do a web inquiry. Thank you, Wisdom, Mina. That's wonderful. Really nice to see everybody, and it's still bright outside, so that's amazing. Yeah. We'll probably kick off in about 3-5 minutes, so you can run away at 7:20. Unless people have questions, you can unmute yourself and ask the questions now. Thank you, Tina. Tina's one of our specials. We got our three special optons: Tina, Bobby, Charlotte, and now Leslie.
Sansi, Sansi.
Yes.
We just had a question come in. I'm just going to read it out to you. So somebody is asking, Jamila is asking for an opinion, LASIK or refractive IOL for high myopia in the new presbyopia.
LASIK or refractive lens exchange for high myopia. So the cutoff is
in new presbyopia.
A new presbyopia. Oh, that's obviously Presbyon. So Presbyon was invented for that specific case. So we assess people for Presbyon from about 40 years old. And if people don't know what Presbyon is, because they're all these different names, but you have to standardize laser names. The first was PRK, just surface, examine on the surface. And the second was a flap, and then and put the flap back. And then the third one is SMILE, where we use just the femtosecond laser and we cut a little lenticule, small incision lenticule, and then it's almost like removing a tiny little contact lens, smaller than a contact lens, out of the cornea, and you can remove somebody's myopia for good. 27-second lenticule. So SMILE is the nicest procedure for myopia. However, SMILE needs a bit more tissue. SMILE gives less dry eye. And the cutoff is probably about, you need to have thick corneas if you have high myopia. So if you've got -7 or more, you're probably in the ICL zone if you don't have a cataract. Yeah, I wouldn't take out the lens just because they're early presbyopia. I definitely never operate on a 42-year-old presbyope with refractive lens exchange. You're asking for a fitness to practice litigation case because the protocol is 50 years old before you do refractive lens exchange. And I'm conservative. They have to show signs of cataracts or something before I offer that, because there's something in between. You can put an ICL and still be 20 years. You know, that -10, you can put an ICL in. If they have enough corneal tissue, like 600 microns, then you can offer SMILE. If there's not enough tissue, we can still do LASIK. Presbyon is a specific type of LASIK with the flap. But the non-dominant eye gets spherical aberrations. And that's actually how I gained my expertise in lens work, because I was doing Presbyon laser refractive surgery. So I was getting a hang of what people were tolerating. Like they will walk around and they'll be like 612, but they're delighted because the spherical aberrations have all been sorted by the laser, and you don't have coma, you don't have trefoil. You just have enough SA with spherical aberration to give you depth of focus. And they were tolerating the -1, -1.5. They were getting really good near vision. So I then adapted it. With every new lens, I compare it with the IHANS, because at St. Thomas's, we ran a randomized controlled trial, a proper full-blown 2-year study, plano -0.75. And 80% of our NHS patients were spectacle-free. Imagine that, 80% in the research trial. So if you come and it's totally routine, please send some routine work to us in the NHS. Please send routine work to St. Thomas's, because my juniors are not getting easy work. It's being sent everywhere else. It helps me train them with bilateral surgery. It helps me train them with toric lenses, stuff like that. Because we're now getting, when I first started, maybe less than 10% of my NHS patients were spectacle free. Now, if you read, Dr.fi is where my NHS patients do my reviews. Google and Trustpilot are my private patients. If you read my NHS patient reviews, they're going up, 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 because I'm doing the high difficult work and I'm learning and doing it on my NHS patients. And I would say about 50% of my bilateral completely routine with a plano 0.75, they're almost spectacle free. They will need an occasional plus 1.5. And because we learned it through Presbyon, so whoever asked that question, very roundabout, if they have enough corneal tissue, I would offer refractive surgery. If there was nothing else going on in the eye at 42 years old, I would make sure that one was plano and the other was -0.5, because I would give them enough longevity to get them to 55 something years old. When they become 55 something years old, they wouldn't have to pay again, because they can have NHS cataract surgery with me. They're paying for the Presbyon at the time. So, you know, that is like all your aberrations. It's like your own multifocal lens, not quite multifocal, your own prescribed, you know, aberrations deleted, still deleted, you know, the optimized laser correction, provided no dry eyes, provided adequate corneal tissue, provided passes the Bobby Charlotte and Tina test. Because, you know, we're really, really strict about refractive errors, and anything that happens in our WIMPO testing rooms and diagnostics and all of that, because refractive surgery is not forgiving. The protocol has to be really, really tight. I've got to go in with a knowledge that we got to have like 0 complications. We're aiming for 0 complications. So yeah, so the patients will then come in, talk to us, we ask family history, make sure there's no glaucoma, blah, blah, blah. But all of those options are available, and then one will be the strongest. The most tricky one is the 50-year-old -2. Then I usually say, bye-bye, come back and see me when it gets worse. Just take off your glasses, you're fine for a few more years. So I tend not to treat that. You know, if you were totally commercial, you'd do the Presbyon, plano and -1.25. But the number of times I've sent away the 50-year-old -2s, you know, we're really more interested in fixing proper debilitating refractive errors that might have retinal detachment risk, glaucoma risk, amblyopia risk. You really need somebody to hold your hands. That's what my practice is. So I hope that is a roundabout answer to your question, Jamila. It covers a bit of everything, but it's all personalized. It depends on what the patient expectations are. Some patients are just not suitable for laser because they have a problem with their life and they think sorting their vision, you take on their problems. So if they're struggling, not because of vision problems, that's why we spend 90 minutes really truly assessing our patients. They have to be psychologically resilient enough, because things could happen. You could come in to get rid of your glasses and you could leave with ectasia. You know, we do all the tests to make sure we don't, but ectasia is a known complication. So that is why all that workup and that team that supports me, that's why we're such a big team for such a small unit. And yeah, I hope this has helped. 22 minutes. Shall we sign off?
Yeah, cheers.
Yeah.
Thank you.
Okay. Thank you, everybody. Save the date, 13th June.
Thank you for joining.
Cheers.
Feedback.
Really appreciate it.
Follow us, LinkedIn, Instagram, blah, blah, blah. Hope to see you in person. Thank you for writing. Call my team. See you tomorrow, Charlotte. Amazing. Actually, we have a team day tomorrow, so see you next Friday. Tomorrow, we've had such a busy month. We've closed clinic tomorrow, so we can debrief all of this. Thank you. Thank you, Charlotte.
Thank you.
Thank you, everyone. Thank you, Leslie. Really great to have you today. Thank you, Jenny. Wonderful. I'm going to sign off now as well. Take care. Bye.